Good day, ladies and gentlemen, and welcome to the National Prevention Week 2019 webinar series. Thank you for joining us. Today's webinar is being recorded, and I will now turn the webinar over to our moderator, David Lamont Wilson from SAMHSA. Please go ahead, David.
Everyone, I am David Lamont Wilson. I'm a public health analyst at the Substance Abuse and Mental Health Services Administration, or SAMHSA, and I am also the coordinator for SAMHSA's National Prevention Week program. I will be your moderator for today's webinar. Today's discussion is a critical one for not only preventionists, but for the entire prevention field. And our distinguished presenters will be discussing the intersection between suicide prevention and opioid misuse prevention, and key strategies to prevent suicide and opioid misuse in our communities. We will be examining the relationship and intersection between these two critical and growing public health challenges, and what prevention strategies and approaches can be used to address them, not only at the national, state, but also local levels. We will be featuring the latest data trends and effective prevention strategies and approaches from the field for us to learn from and hopefully replicate to prevent opioid suicide-related deaths. But before we begin, I'd like to make a few housekeeping announcements. One, please use the chat pod to send us your thoughts and questions throughout each speaker's presentation. There will be a question and answer period following all of the speaker presentations, and I'll pose your questions to our panel at that time. Second, this webinar is being recorded, and it will be available on SAMHSA's YouTube page. So if you have colleagues or coalition partners who weren't able to join us, they can access it on demand. Lastly, we will make the slide presentation available after the webinar, so you'll have the information and resources that we discussed today at your fingertips. And you'll be able to share the data, the resources, and strategies that we've discussed with colleagues and your partners. So today's webinar kicks off the National Prevention Week 2019 webinar series. And due to popular demand, we've expanded this webinar series this year to include more webinars covering more prevention topics than ever before. In particular, our webinars will be examining the intersection between different health themes within substance misuse prevention, as well as exploring special populations who have been significantly impacted by substance misuse trends and consequences. Now, as I mentioned earlier, you can find the past webinars archived on SAMHSA's YouTube page and the NPW website. Now, I would like to introduce our four exciting presenters. Starting our conversation today will be my SAMHSA colleague from the Center for Mental Health Services, Dr. Richard McKeon, who leads SAMHSA's suicide prevention work. We will also hear from SAMHSA's Suicide Prevention Resource Center team, Dr. Kirsten Quinlan and Carrie Nicholson. And from Massachusetts, we'll be joined by Kelly Cunningham, who leads the Suicide Prevention Program in the state's Department of Public Health. Now, before I get to those very exciting presenters, I'd like to take just a few moments to talk about National Prevention Week. Now, this webinar series is one of the many resources, activities, and events available to you through NPW, and I'd like to highlight just a few for you to explore following the webinar. Now, each year, SAMHSA selects an annual theme for NPW, and the focus for this year is inspiring action, changing lives. And this theme reminds us that we can all inspire positive change throughout the year, every day and everywhere, whether we make healthy choices for ourselves or inspire others to do so. The small actions we take can change lives for the better. Now, as you may know, NPW is an annual observance dedicated to increasing awareness of substance abuse and mental health services. The MPW program focuses its activities, its events, and resources on progress in these 3 goals that you see on the screen. Now, capturing your successes and knowing what works for you is important for MPW this year, because we know that organizations, coalitions, and communities are doing great work. Now, you can track your progress and your growth. You can measure your reach and impact, and then we want you to share your successes and progress with us. And perhaps we will feature your organization, your coalition, or your community in an upcoming webinar. So I just want everyone who's on the call to visit the MPW website to connect with us. Now, lots of people in communities get involved and got involved in MPW last year. And by the numbers alone, it was impressive. Check out the MPW 2018 Outcomes Report on our MPW website to see how many communities got involved and showcased their prevention impact. Now, every and each day during MPW in May, we like to focus on different and pressing health themes, and we encourage you and your communities to discuss various aspects of prevention. Now, communities around the country host health fairs, trainings, town hall meetings, Twitter chats, and other MPW activities and events to contribute to our growing conversation, this growing national conversation around prevention. And it's never too early to start to plan your MPW activities. Now, to stay up to date on the latest prevention resources and news and ideas, we want to make sure that you sign up for our Prevention Works email listserv. Each issue features helpful, free resources to strengthen your prevention work in the field. And to sign up, just visit the MPW website and scroll to the bottom of the page where it says Stay Connected. Now, in general, the MPW website is a foundation of effective prevention resources and tools for anyone. And check out the news and announcements section of the site for the latest activities and the latest additions. Now, I've said enough, so in closing, I hope that you're as excited as I am about this new MPW 2019 observance in May. Now, we all know that prevention should happen every day and that everyone has a role to play in making our communities healthier. So, without further ado, I want to introduce my outstanding SAMHSA colleague who happens to be the lead expert on suicide for our entire agency. He comes with great credentials, and I'm going to let him speak a little bit about what he handles within SAMHSA before he goes into his presentation. And I want to thank you so much, Dr. McKeon, for again being a part of our National Prevention Webinar Series.
Thank you very much. I'm certainly very happy to participate in this really important webinar. My role here is as Chief of the Suicide Prevention Branch, and most of SAMHSA's suicide prevention activities flow through the Suicide Prevention Branch, and some of the activities that we oversee include the National Suicide Prevention Lifeline, the National Resource Center, the Suicide Prevention Resource Center, and you'll be hearing from 2 of the outstanding staff from the SPRC as part of this webinar. We have a strong focus on youth suicide prevention. All 50 states have gotten one of our Garrett Lee Smith grants at one time over the last dozen years. A strong tribal effort with our Native Connections programs with over 140 grants currently in the field. And then in focusing on adult suicide prevention, we also have our Zero Suicide grants focusing on strengthening suicide in healthcare settings, and grants to support implementation of the National Strategy for Suicide Prevention. So we are very grateful to be able to oversee this incredibly important work and to be partnering with our other colleagues at SAMHSA and around the country on this critical issue of suicide and substance use, and specifically around suicide and opioids. So that's a quick overview. Do you want me to launch into the presentation?
Absolutely, sir.
Okay. So I'm going to go quickly through a lot of material, so I hope I don't get anybody dizzy. So we're going to be talking about suicide, substance use, and opioids and opportunities for prevention. If there's anything you don't like in the presentation, don't blame SAMHSA, blame me. So as part of the overview, let me mention a couple of really important things. The overall context is like accidental opioid deaths. Suicide deaths in the United States have been rising across the country, which is obviously a very significant concern for all of us. And suicide, in fact, has increased in 49 of the 50 states. The one state that it hasn't increased in is Nevada, but Nevada had among the highest suicide rates in the nation to begin with. So it's not that their suicide rate is low. And actually, half of the states during the period of the last 17 years have seen an increase of more than 30% in their suicide rates. All told, almost 45,000 Americans lost their lives to suicide in 2016. Now, more than half of the people CDC has reported did not have a known mental health condition. But I should mention that did not include substance use and substance use disorders in that. So when you include mental health and substance use disorders, that number becomes a lot higher. This just gives you a sense of the striking nature of the increase in some of these states, typically more rural states for the most part, 57% increase in North Dakota, 48% in Vermont, etc. Just to give you a sense of that and the extent of the problem. And then there are some problems which sadly have been with us for an ongoing period of time. This slide shows you the suicide rate for American Indians and Alaska Natives compared to others of the same age. And among youth, American Indian and Alaska Natives have the highest suicide rate. And actually, as you can see from this slide, that actually doesn't change. Caucasians don't have a higher suicide rate until about age 40 to 45. And of course, suicide is one of the leading causes of death behind unintentional injuries or accidents. Second leading cause of death from age 10 to age 39. And then after that, although suicide goes down as a rating of the cause of death, it's not because suicide is going down in that age group. In fact, it's going up in that age group. It's just that things like heart disease and cancer are intensifying at a greater rate during that period of time. Suicide attempts are also a huge issue. Unlike suicide deaths, suicide attempts have much higher rates among young people and transition age youth, but particularly striking among females, but also among males. And we really need to do a better job of providing care to youth who attempt suicide. And while there's more research that we need, there's reason to think there's at least a significant subgroup of youth suicide attempters who develop significant issues with other psychiatric comorbidities, including substance abuse, later in life. So even if those youth don't go on to die by suicide, there are many reasons for us trying to get them the health that they need. This is the 2017 NISDA data. Just gives you the extent of the issue. Thankfully, not everyone who thinks about suicide dies by suicide, but look at these numbers. In 2017, the estimate is 10.6 million adults over the age of 18 had serious thoughts of committing suicide. Not just any thought, but report serious thoughts. 3.2 million made suicide plans, and 1.4 million attempted suicide. And all of these numbers have gradually gone up over time, particularly in the transitional age group. And these next slides show you that. You can see how the 18 to 25 year-old age group has the highest percentages for suicidal thoughts, for suicide plans, and for suicide attempts. And you can see in particular that spike for suicide attempts over the last 3 years, from 2015 to 2017 on here. This is a slide from the National Institute of Mental Health showing you where, not the rates, but the numbers are. So for suicide deaths, you can see things like almost half are over age 50. Just over a half have been seen in an emergency room for any reason in the past year. Particularly important for us to be paying attention to that. Almost half have accessed health care within the last 30 days. Next to it, you see the same data on suicide attempts. I won't go over each one, but look at substance use treatment. 110,000 suicide attempts estimated by those in substance use treatment. So very large numbers. Here's some data from the National Violent Death Reporting System. This is from the original cohort of 17 states. This is now expanded to 50 states. So within the next year or two, we will have even better information from all across the country. 22% of suicides involve alcohol intoxication, and the estimate is maybe 30 to 40% of suicide attempts. Opiates, including both heroin and prescription painkillers, are present in 20% of U.S. suicide deaths, according to the NVDRS data. Marijuana, 10%, cocaine, 4%, amphetamines, 3%. So a couple of general comments. Substance abuse is second only to mood disorders in its association with suicide. Comorbidity, for example, depression and substance abuse, increases the risk even further. But we know that interventions in the substance abuse field can have significant impacts. For example, suicide mortality among youth has been greatly impacted by changes in alcohol control policy. The increase in the drinking age has been estimated to have saved 600 lives annually from youth suicide. Let me just make this point that there are common risk factors for premature death. Part of the reason for working on suicide and opioid overdoses together is that these common risk factors, if we can intervene with them early enough, can lead to death from multiple different ways. Suicide, for sure, accidents, accidental overdoses, motor vehicle accidents, and in some instances, homicide. Just a couple of words about our youth suicide prevention efforts. We, in these grants that have gone to every state, do have language about collaborating in substance abuse treatment and prevention programs and facilities. We have found in our work that there's a reduction in suicide deaths and attempts in the year after the activities are implemented, which is great, but it does fade after a year, telling us that we need to be able to do more to sustain these efforts across the country. The Zero Suicide Initiative, which I'm not going to go into detail with, has shown that lives can be saved within healthcare systems by having a really systemic, coordinated approach to suicide-related care. And we're really working on trying to encourage the adoption of zero suicide in substance abuse treatment facilities as well. This just gives you a quick idea of some of the things that we're urging to be done systematically. screening and risk assessment for suicide, collaborative safety planning, directly treating suicidal thoughts and behavior, and maintaining continuity of care. Screening is an important area, and now there's huge amounts of data on suicide screening. We now know that question 9 of the PHQ-9, which is a depression screen, is related to suicide deaths and attempts, and so its use is very valuable as a screener in a wide variety of settings. In the emergency department, we've learned that universal screening, in other words, asking everyone who comes through the door whether the reason is because of a suicide attempt, whether it's a substance-related issue, or even a medical issue, found that universal screening leads to double the rate of identifying people at risk for suicide. And in fact, we also know that their risk is just as great as those who come in with suicide-related presenting problems. And we have also learned that by combining universal screening, collaborative safety planning, and post-discharge telephone check-ins, suicide attempts were able to be decreased by 30% over a 12-month period of time. There are resources available at zerosuicide.com as well as at VA and elsewhere around safety planning. SPRC has resources. This is a one-day training called Assessing and Managing Suicide Risk. CSAT has what's called the TIP 50, Addressing Suicidal Thoughts and Behaviors in Substance Abuse Treatment. We have what's called the Suicide Assessment 5-Step Evaluation and Triage. These are wallet cards available in bulk for free. It walks a provider through doing a suicide risk assessment. We've put that on an app called the Suicide Safe app that's available both in the Apple Store and for Android phones. Again, we're really trying to emphasize improving post-discharge safety when people are leaving emergency rooms because they were suicidal. And we think this is likely a really important area as well for those with the opioids. And as I said before, for non-fatal opioid overdoses. The recent SafeVet study from VA showed a 50% reduction using safety planning and telephonic follow-up. So confirming what was part of NIMH's ED SAFE study, and twice as many veterans got connected to outpatient behavioral health care. I'm going to talk just quickly about the Lifeline. Everyone should be aware it's available any time of the day or night all across the country using the number 1-800-273-TALK. Press 1 for veterans. Also, as part of the Interdepartmental Serious Mental Illness Coordinating Committee, we're trying to improve crisis services nationwide. We've been looking at and promoting the Crisis Now model, the idea that every community should have a call center hub, that access to a mobile crisis team and crisis stabilization facilities as part of that. And this slide is making the point, technology is changing nearly every other industry. So at a time when you can track a package halfway around the world, it should not be okay for people to be lost within the cracks of our emergency and crisis systems. One thing that may help to address that, the Congress passed and the President signed into law the National Suicide Prevention Hotline Improvement Act, which calls for the VA, SAMHSA, and the FCC to look at the feasibility of a 3-digit national mental health and suicide prevention emergency number, such as 611 or 412, but kind of modeled after 911. So I'm just going to end with just identifying some critical issues that are worth consideration. We know many opioid overdose deaths that are labeled as accidental may be suicides. Estimates differ. For some deaths, it may not be possible to determine intent. I've been to several states where people have told me that after administration of Narcan to somebody who had taken an opioid overdose, that what they said was, "I wish you hadn't brought me back." It may be impossible to know whether it was a deliberate suicide attempt or it was an accident but someone who was despairing. And non-fatal overdoses, whether intentional or not, may require similar responses. For example, medical care for the overdose, assessment for both suicide risk and substance abuse, and rapid follow-up, particularly when leaving emergency rooms. How should suicide screening be best integrated to substance abuse screening? How can suicide care be best integrated into substance abuse treatment? How can we assist communities heavily impacted by both suicide and opioids? What's the impact of chronic and acute pain, opioids, and suicide? And how can we alter the developmental tragedies, trajectories that lead to both types of tragic outcomes? And are there common factors driving up these deaths of despair, as Case and Deaton, the Princeton economists, have labeled them? So that is what I have to say. I know that was quickly. I probably went a few minutes over time. This is my contact information, and happy to respond to questions later.
That is quite all right, Dr. McKeon. I want to thank you so much for really laying the foundation and setting the stage for our discussion today. I just wanted to say one thing before I moved on to our next presenter. I know I've seen a lot of questions in our chat pod. We are going to make the slide presentation available about this webinar right after the webinar is over. So like I said, you will have it right at your fingertips. So before we start highlighting effective prevention strategies and resources to really help you implement opioid use and suicide prevention in your community, we need to get a better understanding of the current data trends. And so to help us guide us through that landscape, please join me in welcoming Dr. Kristen Quinlan. Now, Dr. Quinlan is the lead epidemiologist for SAMHSA's Suicide Prevention Resource Center, where she provides recommendations to state and local prevention systems on collecting, analyzing, and using existing suicide-related data or building needed infrastructure to improve suicide-related data collection for planning and quality improvement or impact purposes. She is also the director of the Outreach Core for the Injury Control Research Center for Suicide Prevention, where she is responsible for translating the latest suicide prevention research into practice. Dr. Quinlan received her PhD in behavioral science from the University of Rhode Island. So welcome, Dr. Quinlan.
Thank you so much, David, and thanks for having me today. And so as David mentioned, I am the epidemiologist for the Suicide Prevention Resource Center by SAMHSA. I am also the director of outreach for the Injury Control Research Center for Suicide Prevention from the CDC. As David mentioned, and what I'm really hoping will come through in the presentation today is that I am really passionate about this idea of translating research into practice. And so although I only have a brief period with you today, maybe 10 minutes or so, I'm hoping that that'll come through in our discussion. So this is our general disclaimer slide. The objectives that I have today are to start to highlight the connection between opioid abuse and suicide, first using epidemiological data and then reviewing the research that explicitly studies this connection. After that, I'm hoping to point out that opioid overdose, opioid abuse, and suicide have a really complex relationship, and the field's really still unpacking it. So I want to explain why that is and where we are.
Dr. Quinlan, we're unable to hear you at this time.
Hello, Dr. Quinlan. Are you still on the line?
I am.
And Dr. Quinlan is going to reconnect to conference.
In the meantime, if we could queue up Carrie while we wait for Dr. Quinlan to get reconnected. So Carrie, are you available to jump right on in?
Sure. Sure. Hi, everyone. My name is Carrie Nickerson. I am the Director of Grantee and State Initiatives at the Suicide Prevention Resource Center. I was hoping to, after Dr. McKeon and Dr. Quinlan's presentation, to just talk a little bit about what now. So we've heard a little bit about data and some potential ideas for next steps. So what now? So with my short time with you all, here's our disclaimer slide again, which you've now seen a couple times. I wanted to first just say, many of you probably already understand the importance of this, but Dr. McKeon really stressed, and I know from Kristen's slides she would have stressed as well, that it's really important to have accurate data. This information is really crucial for us to help identify what the priority problems are in each of our communities. And this also really helps us narrow in on what the best interventions are to address the priority issues. So building off of what we've already heard, it's important to first think about what data you have from your community and what limitations may exist with these data. And I know Dr. Quinlan will talk a little bit about those limitations when she's back on the line. So some questions to ask yourself, what data do you have from your local medical examiner or coroner? What other local data can you tap into, such as health surveys that point to trends in suicidal thoughts or ideation, substance misuse, or other relevant health indicators to help give you a little better picture of what's happening in your specific community? And this may uncover that the first step might be needed to work a little bit more with your local coroner, medical examiner, law enforcement, health systems, or other partners to improve the data collection so that you can get a clearer picture of what's going on in your community. It's also helpful to compare these data to the national and state data sources to see what you're finding, if that matches the broader trends. Though it's probably likely that you'll also have lots of questions still after looking at these quantitative data sources. So qualitative data like focus groups or key informant interviews can also be really helpful in identifying more of the unique community needs or perspectives that can help fill in some of the gaps in your understanding about the issue in your specific community. So I also throughout wanted to just give a couple examples of some state-level collaboration. And this one is from the state of Rhode Island. So Rhode Island actually went back and tested all of those who've died by suicide deaths for the presence of opioids. They specifically looked at anyone who was 25 and older, and they also didn't just test for the presence of prescription opioids, they also tested for fentanyl and carfentanil. In September 2017, they released a report where they found that about 18% of those who had died by suicide had opioids present in their system. So with this data, they then thought through how they could collaborate more effectively with their partners. They also took a step back and used this information to inform their drug trafficking information and to think a little bit more about how they could reduce the supply of opioids in their state. So I know that going back and testing all suicide deaths for the presence of opioids may not be feasible for many of you, but hopefully this serves as an example of some state-level collaboration and further data gathering that can help inform further efforts. Once you've identified who's being impacted or affected in your community, you'll want to think about what's happening in your community that might put some populations at higher risk than others, and if there are any shared risk and protective factors that these groups may have. These, again, will really help you narrow in on specific populations and strategies to use for addressing these high-risk populations. Then you'll really want to consider who else in your region may be addressing these issues. So I don't know about you, but I find these health issues can feel really overwhelming at times when we think about them globally. And so breaking down the issues into who are most affected and who might already be doing some work in these areas is really critical to identifying where you can make some inroads. The partners you identify, in addition to having done some of this work already, may also be able to give you valuable insight or access to the populations most in need of services, and can also potentially provide some funding dollars or give you some ideas about funding dollars to put behind your efforts. So the good news here is that there are likely organizations, coalitions, and others in your states and communities who are already doing some good work in these areas that you can hopefully really build off of in your collaboration. So I hope if there's only two things that you take from my very short portion of this webinar is that collaboration is really essential for us to be able to address these issues effectively, and that there's likely already some efforts going on in your communities that you can tap into to start really maximizing these collaborations. So another quick example that I just wanted to share, though I know Kelly will also be sharing a little bit about what's been done in her state, is that over the last 10 years, Connecticut has been working to build up their infrastructure, both with their suicide prevention grants and their substance abuse prevention grants, to integrate substance abuse prevention, suicide prevention, and even mental health promotion efforts happening throughout the state. Part of this was that they focused in on regions in their state and looked at integrating the regional boards of health and the substance abuse prevention councils to really help ensure a cohesive approach to prevention. And by doing this, it helped them really address these issues more comprehensively. So they've done some really successful work around addressing access to lethal means, both in healthcare areas as well as within specific communities like colleges and universities. And they've also been working hard to reduce the stigma against access to naloxone and using naloxone to reverse overdoses. They've also been able to put a spotlight to the detrimental impact on families and loved ones when suicides are misclassified as opioid overdoses. So you're also probably wondering, where else can I kind of tap into some resources? And I know Dr. McKeon already shared a couple things, but I did want to highlight a few things that you can use to dive a little bit deeper into these topics and potentially identify some more next steps for your prevention efforts. So first off, if you haven't been to SPRC's website, I hope after this you'll have a chance to take a look at it. We have a real wealth of resources for anyone who's looking to improve their suicide prevention efforts. We also have pages on our website dedicated to state-specific prevention efforts, so you can look at what is currently happening in your state, and also if your state has any SAMHSA suicide prevention grants, and some information about those so that you could potentially collaborate with those grantees in their efforts. We also have several free online courses and self-paced modules, including courses on locating and interpreting suicide data and counseling on access to lethal means. And since I really stress the importance of collaboration, we also have some great partnerships and collaboration resources, including an online module on developing successful partnerships and also a collaboration continuum for substance abuse and suicide prevention. And I've linked to our website at the end of my presentation. And then Dr. McKeon also mentioned zero suicide, and that's a topic we could spend several webinars talking about, but you can learn more about this approach and find tools for implementing suicide safer care at the Zero Suicide Toolkit website, which I've also linked to at the end of my presentation. The National Action Alliance for Suicide Prevention has published numerous resources aimed at advancing the national strategy for suicide prevention, and I've highlighted one specific resource that might be helpful to you all here with the recommended standard care for people with suicide risk. And then lastly, SAMHSA's website has lots of great resources, including this brief that I posted on this slide that discusses the intersection of substance abuse and suicide and the opportunities for prevention. So with that, I also have some additional resources here. SPRC and the CAPT did a couple of webinars recently addressing the link between opioids and suicide. So I've included those links here if you want to dig a little deeper on those. And one of those webinars also focuses on the intersection of chronic pain, opioids, and suicide. So please do take a look at any of those if you'd like to learn a little bit more. And with that, I think I will pass it back to our hosts.
Thank you, Carrie, not only for jumping in at the last minute, but thank you for your expertise. And I just wanted to let everybody know who's on the line where that expertise stems from. Carrie currently serves as the Director of Grantee and State Initiatives. And in this role, she leads the work of the team that provides consultation and support service to state agencies, community organizations, tribal nations, and institutions of higher education, including SAMHSA's Garrett Lee Smith Suicide Prevention Grantees and the National Strategy for Suicide Prevention Grantees. So that's where all of that expertise comes from. Carrie is also a licensed social worker, and that's how she knows the resources and the tools that she has provided to our audience today. So thank you so much, Carrie. And I think we have Dr. Quinlan back on the line.
Yes, you do, and I am so sorry about that. Can you hear me now?
Absolutely. That is no problem. Thank you so much.
All right, great. Sure. My apologies to everyone because, you know, the best laid plans and all that. So, yeah, my deep apologies, especially because I think the information that I was going to present actually set a nice frame for Carrie's presentation. So thank you so much for stepping in, Carrie. So as I was saying, I think I made it to objectives when I cut out. What I was hoping to do today is to highlight the connection between opioid abuse and suicide using epi data. And then really review the research that explicitly studies this connection. I'm going to be talking about how opioid overdose, opioid abuse, and suicide have a really complex relationship. I want to explore those nuances and explain that the field is really still unpacking this relationship. So it's a tough one for the field to understand because there are some serious limitations in some of our data that's available to us, and I want to go over that briefly. I also want to point to research on shared risk and protective factors as a really great space for intervention. I think that's where a lot of this promise is in understanding that connection between opioids and suicide. So let's start with the epi data. The data on this slide come from the 2016 National Survey on Drug Use and Health. This slide reflects the percentage of adults, that's folks who are 18 and older, who report having serious thoughts of suicide in the past year. If we compare those with no history of prescription drug abuse, those are the red bars, with those who have a history of prescription drug abuse, those are the blue bars, we see a pattern. Those who've abused prescription drugs are at higher risk for suicidal thoughts, and this is something that is carried forward nearly every year, and I bet if we went back further than 2011, we would see it there as well. The next slide is a similar slide, but for youth. The data on this slide come from CDC's Youth Risk Behavior Survey through 2015. This time, the slide reflects the percentage of children, those are youth in grades 9 through 12, who reported serious thoughts of suicide in the past year. Again, if we do that same comparison, if we look at those youth who have had no history of prescription drug abuse, those are the bars in green. With those who have a history of prescription drug abuse, those are the bars in blue. We see that same pattern that we saw for adults. that youth who have abused prescription drugs at least one or more times in their life are at higher risk for thoughts of suicide, serious thoughts of suicide. And this is something that holds true every single year. So the epi data is important, but I think it's also important to look very specifically at the research. And the reason why I like to turn to the research literature is because it lets us explore really the nuances of that relationship. So we can see very specific questions about opioids, like whether the dose or the frequency of opioid abuse impacts its relationship to suicide. Carrie mentioned that the FPRC and the CAPS hosted a joint webinar on this very topic. And actually, if you go to that link that Carrie shared, you'll be able to get all of this information in a lot more detail. But briefly, if we look at the research, we can see that adults who receive high doses of prescription opioids are at increased risk for suicide. And this first bullet actually comes from a study of VA patients. The relationship between higher doses of opioids and increased risk of suicide holds true even after we control for demographic and clinical factors. So regardless of the demographics of the patient, regardless of the patient's clinical presentation, this relationship is there, that high doses of opioids equal an increased risk for suicide. Adults who misuse opioids weekly or more are also at higher risk for suicide planning and attempts. And this, again, holds true even after we control for things like depression and other psychiatric conditions. So regardless of the clinical presentation, regardless of the demographics, this relationship holds true. The third bullet that we see on this slide is from a meta-analysis. And a meta-analysis is an interesting way to combine the results of several studies so you can really get a good sense of what's happening out there in the world, because your population that you're studying gets sort of bigger and bigger and your power gets better. Adults who have an opioid use disorder are 13 times more likely to die by suicide than the general population. So what's interesting here and what we can learn from this research is that the degree of opioid involvement matters. People who abuse opioids more frequently, who use higher doses, or who have an opioid use disorder seem to be at particularly high suicide risk. So that degree of opioid involvement seems to play a role in suicide risk. So this is where I want to talk about some of the mechanisms by which opioid abuse and suicide might be related. And it's tricky because there could be a lot of explanations for the relationship. One of the explanations could be that higher doses of opioids offer increased access to lethal means. So maybe people who use opioids are more likely to die by suicide because they have access to a certain method of suicide. Maybe opioids have disinhibiting effects. So they increase the likelihood that a person can and will act under suicidal impulses. Or maybe there's some characteristic like depression or anxiety that explains the link with suicide. So it's associated with both suicide and opioid abuse, and that's kind of explaining that relationship. I think the reality is that any of these hypotheses or even some combination of these hypotheses is entirely possible. The take-home point here is that the relationship between opioid abuse and suicide is really complicated. And understanding the real why and how that they're connected is tricky. And it's not really well understood by the research literature as of yet. And one of those reasons is this limitation that we have with regard to our opioid overdose data. And Carrie touched on this a little bit, and Dr. McKeon did as well. I also saw a question pop up in the chat early on by Lori asking the same question. What is intent, and how does that sort of play into understanding opioid overdose data and suicide death data? When classifying a death as a suicide, a coroner or a medical examiner has to determine two really important things. So first, did the person know that the dose was likely to be lethal? Did they have enough experience with the drug to know that it was likely to, have an effect like that? And second, what was the person's intent? And this intent question is so challenging because intent's really left up to coroners and medical examiners, and they may have their own biases or opinions about what constitutes level of intent. The intentionality continuum that is it an accident or is it a suicide? It's made even more complicated because, sometimes even the decedent might not know what his or her true intent is, and it's left to the coroners and the medical examiners to make that determination. So it's super tricky, and this matters because there's a very strong likelihood that we are underestimating the number of opioid-related deaths that are actually suicides. This means that actual suicides might be going uncounted because coroners and medical examiners have to determine that issue of intent. And this matters a lot for a lot of reasons. First, the underestimation is likely not random. Some groups seem to be more affected than others. Nate Wright is an epidemiologist out of Minnesota who I've done some work with, and he estimates that about 28% of Native American deaths are misclassified as accidents or accidental overdoses when they're really suicides. And that matters. It matters for planning. It matters for evaluating the outcomes of our prevention efforts. We use data in planning and decision making. And if that data are incorrect or misclassified, that's important for us. We also use data for research purposes. We want to understand the connection between overdose and suicide. And if suicides by overdose are misclassified, it makes this relationship tricky to figure out. So where there's a lot of promise, I think, is, in thinking about the relationship between opioid abuse, opioid overdose, and suicide by looking at their shared risk and protective factors. If we look at physical health problems like chronic pain, headaches, backaches, these are associated with opioid abuse, and these are also associated with suicide. Behavioral health problems, depression, anxiety, these are well-studied risk factors for both opioid abuse and suicide. They play out in both youth and adults as risk factors for both of these public health issues. I saw trauma and adverse childhood experiences come up earlier in the chat as an issue, as a shared risk and protective factor for opioid abuse, overdose, and suicide, and that's absolutely true. That plays out in the research. As does social isolation. We know that youth who have fewer than one friend are at risk for suicide. We know that youth who live in rural environments, particularly white youth living in rural environments, are at risk for suicide. This social isolation factor seems to play a role in opioid abuse and in suicide. And I think, as Dr. McKeon pointed out, and this is so true, these shared risk and protective factors offer some unique opportunities for integrated, collaborative prevention work. They let us reach some really at-risk audiences. They help us avoid duplication of efforts. And I think I originally come from the substance abuse prevention world, and I more recently began focusing on suicide prevention, and what I've seen is those commonalities. Opioid preventionists and suicide preventionists, they're addressing those same upstream risk factors, and both are following that basic public health approach to prevention. There's a lot of commonalities here. So we have this really neat opportunity, I think, to galvanize new partners, consolidate our efforts, work collaboratively. And if we use a comprehensive integrated approach, I think we have an opportunity to address both public health issues. And so there's my contact information, and I appreciate your time on that and your patience with my audio cutting out. So thank you all so much. I'm going to turn it back over to David.
Wow. Thank you so much for helping us better understand this interrelation, Dr. Quinlan. Also, thank you for helping me understand more of the challenges and the opportunities related to just simple data collection of the intersection between opioid use and suicide. Thank you. So our last speaker is Kelly Cunningham, and Kelly's going to help us. She's going to give us a better glimpse of what prevention efforts look like at the state level in response to suicide and opioid crisis. And I'm pleased to welcome Kelly from the great Commonwealth of Massachusetts. Kelly is the director of the Suicide Prevention Program at the Massachusetts Department of Public Health. She has been in the suicide prevention field for more than 11 years. And in her first 7 years, she led the Community Education and Outreach Program in Boston, talking to middle schoolers, high schoolers, and college students about suicide prevention. Now, since 2014, She has been at the Massachusetts Department of Public Health in the Suicide Prevention Unit, first as the Assistant Director and now as the Director. She is also the Project Officer of Massachusetts SAMHSA Garrett Lee Smith Campus Suicide Prevention Grant, which does support youth suicide prevention programs in the state and promotes Zero Suicide Initiative. Take it away, Kelly.
Thank you very much, David, and thank you for inviting me to share with you today. What I'm going to do is talk a little bit about some few statistics just to show the trends between suicide and opioid deaths in Massachusetts, and then I'll move into talking about some of the strategies that we're using here, as well as some of the lessons that we've learned and some of the lessons that we're still learning. So first, looking at suicide data, and as you know, the CDC vital signs, as indicated in June, we are one of those states that saw a 35% increase in suicides. And this slide shows the 35% increase occurring between 2005 and 2015, with middle-aged men still being the highest number of suicides. Our 2016 data, which literally was just approved about 2 hours before this webinar started, did show a slight increase of suicide deaths to 638. This slide is taken from our August 2018 opioid quarterly report, and it shows the number of confirmed and estimated cases of opioid-related overdose deaths for all intents. And compared to suicides, opioid deaths have seen a 200% increase between 2006 to 2016. Current 2017 data shows a slight decrease with a total number of deaths equaling 2,069. This represents a 4% decrease from 2016's total confirmed and estimated cases, which you can see is 2,154. And looking back at suicide deaths, it's important for us to look at circumstances associated with the suicide. And as you can see in 2015, we did see that 27% of those who died by suicide did have an alcohol and or other substance use problem. In 2016, we saw a slight increase to 32% for the same circumstance. But it's also important to remember that in many cases, this wasn't the only circumstance at the time of the person's death. So how are we dealing with this crisis? And an area where we're spending a great deal of time on is in our prevention strategies. And as you can see here, I've listed 4 key prevention strategies we are currently working on. They are screening, life skills, systems change, and trainings. So the first strategy I'd like to discuss is screening. And SBIRT, as you see up here, which stands for Screening, Brief Intervention, and Referral to Treatment, is a screening tool that can be utilized in different settings and specifically used to determine substance use. In March of 2016, the Massachusetts legislation enacted an act relative to substance use treatment and education and prevention, also known as the STEP Act. This act requires schools to conduct annual screenings of students in 2 different grade levels. And the benefit of this is it connects students with the trusted adults. It establishes healthy decision making. It may actually connect a school with a student who would otherwise go under the radar. And some schools have even included additional questions around social, emotional, and behavioral health. And sometimes, for them to add a question to something as simple as, in the last 2 weeks, have you felt so low that you've lost interest in usual activities, can start a conversation about their mental health and additional screening if necessary. And as part of our Garrett Lee Smith grant through SAMHSA, we are working with 2 hospital systems that have implemented universal screening for suicidality. Typically this is the Columbia Screening Tool, CSSRS, and SBIRT. And 3 years ago, screening was only given to someone who presented as suicidal or under the influence of substance use. Since the grant started, every patient between the ages of 10 to 24, regardless of why they are there, receives both screenings. And it should also be noted that universal screening has been adopted for all age groups within the hospitals. The benefit of this is by offering screenings universally, they are reaching many more individuals who may otherwise slip through the cracks. It offers open conversation about a topic most have not felt comfortable discussing. As you've heard, and we just saw this recently in Dr. Quinlan's slides, that we know there are shared risk and protective factors between opioid use and suicides. With this in mind, we have incorporated this important preventive strategy of teaching life skills as a technique that will be useful for both opioid use and prevention of suicides. Developing healthy life skills is an important aspect to anyone's recovery and prevention. Incorporating these lessons and teaching the proper skills helps the individual provide strategies around substance use, suicide, mental health concerns, and many other traumas. It's important to note that with any systems change, collaboration is necessary, whether it be within an organization such as a hospital or in developing collaborations with outside organizations that help strengthen the work being done. Each of the system changes below demonstrate how effective this strategy can be. So a big change in our substance use treatment world is understanding the understanding of co-occurring disorders, and that treatment must fit the needs of the client. That has become very important to us here. And many of our treatment facilities are incorporating practices that address both the addiction and the mental health diagnosis, helping to assure a more effective treatment for the whole person. Also, for a number of years now, many police departments across the state have instituted crisis intervention teams. The addition of a mental health clinician has helped tremendously when dealing with an individual who is in crisis. They can often help divert someone who would have been arrested to now be getting diverted to help. When considering the stigma surrounding mental health and substance use, this is a different approach to handling a crisis without escalating a situation. And then the final strategy I wanted to talk about for systems change is around zero suicide and what we are doing about that here in Massachusetts. We're very fortunate to have 2 SAMHSA grants for suicide prevention, the Garrett Lee Smith Grant, which focuses on ages 10 to 24, and the National Strategies for Suicide Prevention, which is for ages 25 to 64. Within both grants, we are implementing zero suicide with a number of healthcare and behavioral healthcare settings. I've already mentioned in a previous slide how screening has been implemented within the GLS grant. Now for the NSSP grant, we took a more community collaborative approach. We selected a region of the state that is seeing higher suicide rates for this age group, and as it happens, has also a significant opioid and substance use issue. This location is on Cape Cod and the islands. We've established a zero suicide learning collaborative which brings together the major healthcare system in this region. I'm sorry, I hope that wasn't me. Hello?
Yes, we're still on conference.
Okay, thank you. I don't know what that was. We've also been very fortunate as part of our learning collaborative on the Cape is our sister agency, which is the Department of Mental Health, and they're the lead for this grant. They have also been implementing zero suicide in all of their state-run inpatient settings, one of which is located down on the Cape. And finally, one of our very fortunate things is we've been able to have the major
joining the main conference
treatment center for this region join our learning collaborative. And it's our goal that by implementing zero suicide in a substance use treatment center, that will be able to better treat the patients through their recovery and beyond. And I'm hopeful this model will be something we can replicate in other treatment facilities in the future. So as with any prevention strategies, training is very important and an area we have always strived to provide in Massachusetts. Such a training offered by our program is a training specifically designed to enhance frontline substance use counselors' knowledge and skills of suicide and the close relationship between substance use and suicidality. This training, whenever we offer it, is always full. And it's no surprise that a number of the trainings that we are offering are what we call crossover trainings. And the goal is to make sure that both fields are aware of these offerings so that they can best support their clients. Each year, we offer a 2-day statewide suicide prevention conference. And at our last conference in May, we introduced a workshop focusing on opioids and suicide. And of the 500 participants that attended, over 150 of them went to this particular workshop, and it was by far the most popular workshop that we had. We knew that this was something that people were interested in, but we had no idea about the demand. And as a result of this, we're in the process of actually making this into a full-day training, and it's actually going to be 2 different tracks, one specific for clinicians and the other for community health workers. And we look forward to be able to increase the knowledge of those who attend these trainings across the state. And finally, thanks to the CDC, the Department of Public Health has been awarded an opioid public health crisis grant for this current fiscal year. And as part of this grant, our program will be working with the substance use field, such as using a bunch of trainings like the one that I just mentioned, as well as several others, such as psychological first aid and post-traumatic stress management. We're also going to be able to help those who attend those trainings do some case consultation. So they'll receive some technical assistance from the provider that will be doing this with us. And then we'll also be doing a needs assessment for peer recovery coaches to better understand their role and where gaps may reside. And finally, what have we learned? Well, certainly we've learned that we still have a lot to do. And some things work really well, while other times we need to take a step back. But a big step forward for us is learning that we need to work better together instead of in our own silos. And it's so easy for us to get lost in our own little world. And when I say our own silos, I'm even talking within our own department here at Department of Public Health. I'm always amazed each time I meet with somebody and we talk about what we're doing and somebody says, wow, we're doing that too, or is that something that we could use in our program? So we need to do more of that type of work to really be able to see bigger results. And I have to tell you, as working as part of the SAMHSA grant down on the Cape, we saw this right away when we brought all these community providers together and they started to hear what other individuals or other organizations were doing. Some of them were floored. They had no idea that this work was happening or that this work was something that they could bring into their own workplace. So this, we feel, is a big step forward, and we're really hoping that we can make a bigger difference with this. So just like everyone else, I included some resources here. Some of them are specific to the stuff that we have going on in Massachusetts, including the quarterly report, as well as directly to my program here. And again, I want to thank you for allowing me to speak today. And if you have any questions, please let me know.
Thank you so much, Kelly, not only for giving us some real-life, on-the-ground examples and strategies, but more importantly, the lessons learned that you provided. Now, before we get to my favorite part of the webinar, which is the Q&A section, where we actually try to address all of the questions that you guys have been patiently putting in the chat pod, I just wanted to throw up this slide just to reinforce some of the resources that have already been shared. Here are a few SAMHSA resources that you may find useful for your opioid misuse prevention or suicide prevention work. Also, I would be remiss if I didn't mention that there are some high-profile media campaigns, not only at the national but also the state level, such as the White House's Crisis Next Door media campaign, which offers resources and content that may strengthen your own prevention communication campaigns. Now, the best part. I think we have about 20 minutes that we can try to address as many of the questions that have come in from the audience. And as I've mentioned before, with your questions, please use the chat feature to share them with us. And I'm going to start throwing out some questions to the panel. I've kind of gathered the questions by the most aligned topics here. So I'm just going to start with one that I think you could speak to, Kelly, right off the bat.
Okay.
Which is, no, I'm sorry, Kelly. Let me start with Carrie. Because we've gotten a lot of this question. What other local data on suicide can you use when funding mechanisms are limited? Carrie, you can start, but any of the panelists, you can chime in afterwards.
Sure. Well, I imagine that Dr. McKeon and Dr. Quinlan will have some great thoughts on this as well. But each state will likely have some data portals that you can tap into. There are certain states that have data dashboards, such as Colorado and Oregon, I know have dashboards where you can look down on a community level at what's going on in your state. You can also access more targeted information through Whiskers data. And then also, again, thinking creatively about just knowing what's collected in your area, what access you may have to local health systems, your local medical examiner or coroner data. Just again, doing a bit of a landscape of what exists out there that you can tap into. Youth risk behavior surveys, other things. It all kind of depends on your audience that you're looking at and the population specifically. But again, I wonder if Kristen and Dr. McKeon will also have some additional thoughts to share, and Kelly as well from her own state level.
Well, this is Richard McKeon. So I would mention two things that I think are particularly valuable data sources. So one is the National Violent Death Reporting System, and with its expansion now into every state from that, as of this month, or the end of last month, all 50 states now have access to the National Violent Death Reporting System. Now, the states that just got the National Violent Death Reporting System, and there were about maybe 8 or 9 of those, will need a little while to be up to date in terms of their data collection and having that available. But every state will have that. And then every state will have the potential to do what Colorado has done, which is to make that data available on a county-wide basis, where you can only, in addition to find out the number of deaths by suicide, etc., as important obviously as that information is, but can also find out the circumstances surrounding that death, including the involvement with substances. So that's one tool that will be really important, that is available in many states right now, and in those states where it's not available, it'd be important to track on because it'll be coming online in the not-too-distant future. The second thing, and I think this is related, is very relevant for both suicide and for opioid overdoses, is that there is now a system called Essence or BioSense, which does syndromic surveillance in emergency rooms. It was originally set up to track in case of bioterrorism or infectious disease outbreaks. But it is tracking on opioid overdoses, and it is tracking on presentations in emergency rooms for suicide. About 2/3 of the emergency rooms in the nation are now reporting data through that system. So we have been working with CDC, who in turn have been working with local departments of health to find ways for that information to become more available to state suicide prevention coordinators, to public health officials, to others who may be able to utilize that information for prevention planning and for actually intervening.
I've received a lot of questions about screening, so I'm going to throw out a general screening question to the panel. When you talk about universal screening, what does that look like? Where is it administered, and by whom? To tackle that.
Well, this is Richard McKeon. I'll start with that. I think that the issue is really that it depends on what setting that you're in. There are some settings where the likelihood of uncovering in a screening effort that somebody is at risk for suicide is going to differ depending on what that setting is. So, for example, you will find more suicidal kids, or at least a greater proportion of the screens will be positive if you're screening in a juvenile justice facility than if you're screening in a school, which would be more universal. So I think it's particularly important in areas where there's reason to think that there is higher risk, like mental health settings. So the idea of screening universally for suicide risk in mental health settings. I think a strong case can be made for screening universally in substance abuse settings. We've mentioned the data on screening universally in emergency rooms. In primary care, the United States Preventive Services Task Force report was inconclusive about whether it makes sense to universally screen for suicide in primary care. But they have recommended universal screening for depression. And so what we would say is that, when universally screening for depression, it's important to use a screener that also asks about suicide, such as the PHQ-9, where question 9 is the question about suicide. So anyway, but there's much, much more data now available about screening and screening instruments than there was a decade ago. So I'll stop there.
Well, the good news is, Dr. McKeon, you answered about 3 of the screening questions. So I'm going to jump to a question that I think is good for the whole panel. And I'm not even quite sure if there's a real clear answer, but it's a great question, which is, what is the evidence for reductions in accidental or suicidal deaths from opioids when naloxone prescriptions are readily available?
Could you go over that again?
What is the evidence for reductions in accidental or suicidal deaths from opioids when naloxone prescriptions are readily available? Like I said, I'm not quite sure there's a clear answer, but I thought it was a fascinating question.
Yeah, I'm not aware of any evidence on that in the suicide research literature. There may well be, information on that in the substance abuse literature, but I'm not familiar with it.
Kristen, could you expound on that?
Yeah, I was just going to jump in. No, I actually don't have any information on that either. No, it's a good question.
Okay. Here's another question. If a person using opioids commits suicide in a different way, not overdose, would you still link the two?
So this is Kristen. I saw that come in on the chat. I think that, what's interesting about the National Violent Death Reporting System that Richard cited is that it does involve an investigation of suicide-related deaths, including information about whether the decedent has used various substances in the past or been treated for a substance use disorder. And so, there are ways of sort of looking at the data to examine the likelihood that someone who has, had an opioid use disorder in the past then dies by suicide. So, we can get information on that in terms of linking the two.
Next question. What are the suggested environmental strategies for addressing this? I know we touched on it briefly, but if anybody wants to go a little deeper.
This is Carrie. I guess, I think, again, it's important to first understand, who is the population you're looking to focus in on, and what are the issues that they're facing, what are the risk and protective factors that are specific to that group, and then thinking about the different levels in which that person interacts with both their community, their families, their systems such as schools, health systems, and where might there be those points to identify these issues and ultimately hopefully prevent them. So training families to understand the warning signs of both issues, talking about screening initiatives that we've talked about here, potentially linking different preventionists with information about the other health issue and how to kind of identify and connect to some of those resources, and also certainly pieces around the access to opioids and other lethal means that have been discussed at this point are also very important in this context.
Thank you. I'm going to steer to a lot of training questions that we've gotten, and Kelly, you may be able to speak to this specifically. Can you share an agenda from one of the trainings? It would be great to host locally, is what a few people have mentioned. And then the second training question that came in by a few people are, what are the life skills being taught?
Okay, so I'm going to assume on the first one asking about the agenda, they must be referring to a specific training, and we certainly can share the agendas. Sometimes if it's something that we're currently offering, like next week we have a trauma-informed training, the objectives are listed on our training calendar, which is through my link that I did share on there for the suicide prevention program. So you can get it that way, but you can also message me and I can get you an agenda for a particular training if that's what somebody is looking for. As far as life skills, they've been doing a lot of stuff, around using a lot of things with DBT, so a lot of mindfulness type stuff, teaching them, how to be able to better interact without using substance use. So there's been a lot of work with peers as well, and what are some of the things that they can learn together about their life skills and how they transfer that outside of a facility if they're in a treatment facility when they're learning these skills. So there's a broad amount of different types of learning skills that are being taught all over the place.
All right, I think I have one more question that I have time for. So I'm going to pose this to the group. Did the rise in suicide from 1999 come from more suicides due to better tracking?
Yeah, this is Richard McCann. I would just say I think there's virtually no chance that that's the case. That while there may be some improved tracking in some areas, what you see, are significant increases across the entire country. I think there is virtually no chance that that is due to improved reporting. I wish we could just say that it's not that more people are dying, and we're just tracking better. But I'm afraid, in fact, that more people are dying.
And I would just follow up on that by saying that, there is room for improved reporting in that, I'm thinking of CDC who sponsored some work on helping medical examiners and coroners on the ground through, toolkits and apps and, sort of thinking about the development of that. So that when folks are classifying a death, they sort of have a checklist in their heads to go through to determine whether or not it is a suicide or an overdose. And so, when we're talking about tracking, that question about tracking just brought it up for me that, we really need to think about, improving our ability to classify deaths appropriately, and also to think about improved training, particularly I think for our coroner systems. Medical examiner systems are one type of system used to classify deaths, and then other states have coroner systems who can sometimes be elected officials without necessarily the medical training that a medical examiner would have, and so there's certainly room for improved training and tracking.
Thank you. So we're almost at time, and before I close, I just wanted to thank the over 1,000 people who registered for this webinar. I want to thank you for the great questions that came in. Very, very huge thanks to our distinguished speakers. We have not only started this important conversation today, but we hope to continue it. And we hope that everybody who registered for this webinar will join us for our next webinar in November, at which we will be discussing strategies and inspiring examples for how you can better market the impact of your prevention programs, your campaigns, and your initiatives about how national health observances like NPW or National Prevention Week can amplify your prevention efforts. So please visit the NPW website at www.prevention-week to register today. We hope that this information has been valuable to you, and please tell us what you thought about this webinar by filling out the post-meeting survey that will pop up once this meeting ends, because your feedback is always valuable to us and will help us plan our future webinars. So for more information, like I said, visit www.samhsa.gov/prevention-week. I thank you for your questions and for your time today.
Thank you. And this does conclude today's webinar. We thank you all for your participation. You may now disconnect.